Hello, it's me again, your lecturer Sarah Galar. Today we're gonna discuss with you your last lecture. Today we're gonna discuss with you the laryngeal disorders. The content our lectures today's lecture. It is the structural peculiarity and function of the larynx, the sound production mechanisms, singular voices, mutation of voice in children, acute and chronic disease of larynx, acute laryngotracheal syndrome during upper respiratory viral in children, acute and chronic stenosis of larynx, conservative and surgical treatment, intubation and tracheotomy, benign and malignant tumor of larynx, laryngectomy, foreign bodies of larynx, bronchus, esophagus, and burning of larynx, and fibroendoscopy and esophagoscopy. The larynx is commonly referred to as a voice box. It continues the basic line of conduction that leads the laryngopharynx into the trachea. Level with the fourth through the sixth vertebrae, the larynx is located along the anterior midline of the neck. You see in that slide, it is the connection of the larynx with other upper respiratory tract way. You see it is the blue one, it is the nasal cavities. Here we can see the oral cavity, and below them, behind them, there's the nasopharynx, and anterior laryngopharynx, and below the oral cavity we can see between the trachea we can see the larynx. The larynx consists of four basic anatomic components: the cartilaginous skeleton, the muscles, and the mucosal line is very important structures of the larynx. In that slide, we can see the anterior view and the right lateral view of the larynx. About the skeleton, we say it consists of the 9 various cartilages create the structure of the larynx. The 3 of them it is the unpaired, the massive one, and the 3 cartilages are a paired one. The unpaired one is the epiglottic, thyroid, and cricoid cartilage. Okay, it is the epiglottic cartilage. It is the thyroid cartilage and cricoid cartilage. Even in the back view, we can see the other cartilage. I mean, just the arytenoid cartilage and corniculate cartilage. Even we can see. In that slides, you can see the parts of the separately color of this cartilage. For example, the gray color, it's the it's the green color, it's the epiglottis. You can see the yellow color, it's the cricoid cartilage. Even we can see just the corniculate cartilage in these slides. One of the important cartilage, the paired, it is the arytenoid cartilage, which it is just which the vocal cords embedded them. It's located vocal cords located between the thyroid cartilage and arytenoid cartilage. The arytenoid cartilage in the it looks like it's a triangle. In the apex is located the corniculate cartilage. Here it's the base of this. It is the vocal process and the muscular process. It is the vocal process and the muscular process of arytenoid cartilage. There are 2 joints. One of them is the cricoarytenoid joint, which it is located between the arytenoid and cricoid cartilage, and it is the cricothyroid cartilage, which is located between the cricoid and thyroid cartilage. The 9 cartilages in midline of the neck, they connected each other. They are embedded each others with 8 ligaments. We call them ligamentum thyroideum, ligamentum thyroepiglotticum, hyoepiglotticum, cricotracheal, cricothyroideum, plica vocalis, plica adiepiglotticum, and plica glossoepiglotticum medial and lateral. The various parts of the larynx are very closely connected tissue membranes. One of them is the thyroid membrane, was seen in the start of the neck and is perceived by the internal laryngeal nerve and superior laryngeal artery. It extends from the upper border of the thyroid cartilage, you can see here, upper border of the thyroid cartilage and is pierced by the internal laryngeal nerve and superior laryngeal artery here. It extends from the upper border of the thyroid cartilage to the greater wing of the hyoid bone. The quadrangular membrane is free at the top and bottom but attached posteriorly to the arytenoid cartilage and anteriorly to the side of the epiglottis. The lower free margin forms the post-vocal cord, or we call this the vestibular form. In these slides, we can see all this. It is the inlets, airway inlets. We can see all the connecting of these the vestibular ligaments, the vocal ligaments, just the cricothyroid ligaments here. Okay, in that pictures you see just the vocal ligaments. It's located at the arytenoid cartilage and the thyroid cartilage. It is the sagittal view, but in that pictures we can see the axial view of the vocal cords. The laryngeal muscles are segregated into two different groups depending on their designed function. Extrinsic muscles, which are designed to lift the larynx during the act of swallowing, and intrinsic muscles contract. They are capable of altering the length, position, and tension of the vocal folds and create variances in sound. The extrinsic muscles, you know this from the topographic anatomy subject, it's the musculus sternothyroideus, thyrohiatus, sternohiatus. I mean that the first sternothyroideus and thyrohiatus, the larynx is playing a role in these muscles, but others, I mean just the musculus sternohiatus, omohiatus, telohiatus, gastrus, and genihiatus. The larynx is not playing; it is just connected. It's just surround them. But intrinsic muscles, it is works as a purse string to close the opening of the larynx when swallowing, protecting the larynx. There are two muscus arioepiglotticum and thyroepiglotticum. The muscles of the larynx, intrinsic muscles now, it's which play a role in just the vocal cord. It's connected. You see the obliqua arytenoid. It is the narrowing the inlet, the thyroepiglottic. It is the it's the arioepiglottic. It is just the widens of the inlet. In other slides, okay, we see the muscles serve as the opening of the glottis as well as the tenseness of the vocal cord, thereby keeping it open for respiration and helps us vocalize. For example, the musculus cricoarytenoides, lateral arytenoides, transversus arytenoides, the obliquus cricoarytenoides posterior, which we call this the musculus posticum. You should just we should underline here that only musculus posticum. I mean, just only this, just abductors, and just open the vocal rhineglottides. I mean, and musculus arytenoides, musculus cricoarytenoides, and musculus vocalis. All these include the intrinsic muscles. In that slide, you can see the actions of the intrinsic muscles. Okay, it is, you see, it's the action of the posterior cricoarytenoides muscles. I mean, just the musculus posticum. It is just the opens the rhineglottides. But other muscles, actually, for example, here you see the actions of the lateral cricoarytenoides muscles. All this just to close the rhineglottides. Actions of transverse arytenoid muscles, it's also just the closes. It's the action of vocalis and thyroarytenoid muscles. It's just a change of the tenseness of the vocal cord. Cricothyroid muscles here tense the vocal cord. Okay, the thyroarytenoid is vocalis, it's relaxing. The lateral cricoarytenoid is also adductor. Okay, we say only posterior cricoarytenoides muscle is adductor. The nerve supply of the larynx, it's a very interesting innervation of the larynx. The sensory nerves above the vocal cords, we say the internal laryngeal branch of the superior laryngeal branch of the vagus, and below the level of the vocal cords, the recurrent laryngeal nerve is innervated. The motor nerves, all the intrinsic muscles of the larynx are supplied by the recurrent laryngeal nerve, except the cricothyroid muscle is supplied by the external laryngeal branch of the superior laryngeal branch of the vagus. The vascularization of the larynx is supplied by the superior and inferior thyroid artery. Okay, it is just a parenthesis. I want to just show you just the position of the vocal folds after the damaging of the vagus nerve. We're going to talk about that during the nerve damaging of the voice disorders. It's the latest part. Okay, it is the sagittal view of the larynx, the frontal, it is this frontal section. In that we can see the laryngeal vestibule. In that here we can see the larynx is divided into three parts, in the three floor. The first floor we call the laryngeal vestibule. The second floor, it is the vestibule, it is the glottic area. In the glottic area, it's created between the it is located between the vestibular and vocal fold. I mean, just the true and false vocal fold. And below them, we call the infraglottic part. It is the third part. Okay, the laryngeal sinus, we mean it is the glottic part. About the lymphatic drainage, it's also subdivided into supraglottic, infraglottic, and glottic. Lymphatic network more up in vestibular part. The function of about the physiology of the larynx, function of larynx, it has just the main functions. The first important functions, it's the non-biological biological function. It is the protection of lower. It is the respiration, protection of the lower airways, the phonation or speech. It is the non-biological function. Fixation of chest helps in promoting the venous return. All this includes the function of the larynx. Okay, it is during the inspiration, it's during the phonation. Protection of lower respiratory tract. In that slide, you can see the protection of the lower respiratory tract. Phonatory expiration in these slides, we see that occurs when the person is attempting to speak. Vocal folds on both sides approximate along their entire anterior-posterior dimension. This can be tested by asking the patient to say E while performing laryngoscopic examination. In non-phonatory expiration, vocal folds are gently adapted. The human speech has three components. The phonation, which we call this the sound production. Resonance, it's related with the amplification and filtering of sound. And articulation, we mean just the formation of the words. The sound production occurs due to the vibration of the mucosa at the inner edge of each vocal cord. The mucosal cord of the vocal fold is highly specialized for phonatory vibration. The pitch of the voice is controlled by changes in length and tension of the vocal folds. Articulation of voice, we mean it is the final modification of the voice occurs in the mouth, nose, and throat, where the tongue, palate, cheek, and lips are involved in articulation. The sound of the human voice is greatly determined by the resonance of the upper vocal tract. In that slide, we can see it is the coronal section, and it's explain us the floors of the laryngeal cavity. The vestibule, which is the area above the vestibular fold. The ventricle, which is the pocket-like recess between the vestibular and vocal fold on both sides. and in the infraglottic cavity, which is the area below the vocal cords. It is the sagittal view of the larynx. The first space in the larynx is called the vestibule. Here, just beneath the vestibular fold, is the ventricle, which extends the lateral and is connected internally to a small sac called the saccule. The saccule has special secretory glands and the secretory cells that produce a secretion to keep the vocal cords the moist. It's plays the role moisturization. Sometimes during the who is working in industrial sphere, there this glands is atrophied. That's why it is the it leads to the laryngitis sicca, the such of the disease which we call this the laryngitis sicca. Beneath the ventricles, the true vocal cord that extends from the three vocal processes of the arytenoid cartilage to the backside of the cartilage. Length of the vocal cords, you see, it's the different in children, in male, even in female. We should discuss with you about the structural peculiarity of larynx. The plica vestibularis forming by fragile connective tissue, gland, and muscles filaments. The mucosa of cavitus infraglottica is thicker, fragile, and there are many glands. There are many lymphadenous tissue in ventricles and larynx. It is developed in children. These all contribute to appear the laryngeal edema. The rank space, we mean this potential space has scanty subepithelial connective tissues and lies under the epithelium and or vocal cords. It's bounded by above and below arcuate lines under the anterior chemisura and posteriorly vocal process of arytenoides. Rankus edema space results in fusiform swelling of the membranous vocal cords. About the examination of the larynx, we call this the laryngoscopy. The laryngoscopy divided the direct laryngoscopy and indirect. For the direct laryngoscopy, we need to use just the scope. The scopes may be just a rigid and a flexible scope. For example, in that pictures you see it is the flexible scope and indirect oral laryngoscopy. For the indirect laryngoscopy, the first time the Mackenzie just reviewed these methods, we are using the mirror for examining the laryngeal area. We said a laryngoscopy is the usual inspection of the larynx interior. Direct and indirect laryngoscopy distinguished. Direct laryngoscopy is used in cases where inspection of the speculum is infeasible in infants, or if an inspection is not sufficiently informative. Direct laryngoscopy is also used when specimens of live tissue have to be taken for histological studies, or if a new growth should be removed. At the present time, direct laryngoscopy preceded the intubation of the airways under anesthesia and is the first step in tracheobronchoscopy. Direct laryngoscopy in children can be performed without anesthesia. In that pictures, we see it is the rigid scope. It's the zero. We are using just a 70 and 90-degree scopes. This is during the laryngoscopy. We can see the two vocal cords are purely white that meet in the midline on phonation, and the surrounding structures are the pink color. Indirect laryngoscopy is carried out using a laryngeal speculum. The patient is asked to utter a long sound and take a deep breath during phonation, and then during the inspiration is inner surfaces of the larynx become visible in two phases of the physiological activity. Okay, it is the pictures of the indirect laryngoscopy. Okay, with that method, with the mirror, this is the technically we are examining this laryngeal area. About the video stroboscopy, laryngeal video stroboscopy enables us to view the vocal folds to see how they vibrate. It is the stroboscopic view. We are doing this during the voice disorders, actually. The vocal cord covered by the squamous epithelium, it is the highly specialized for the phoniatry. The larynx is responsible for creating the origin of sound. However, it takes a combination of other various structures to produce recognizable speech. Constricted the walls of the pharynx create the common vowel sounds. Voice requires resonation, which is provided by the pharynx, the oral cavity, nasal cavity, and the pharyngeal sinuses. Controlled movement of the tongue and lips create the recognizable speech patterns humans can understand. The singer voices about the voice classification is a subject about which there is much disagreement. It is important to remember that the voices of high school age singers feel little, if any, real relationship to adult, professional, and classifications. We classify voices as a high, middle, or low. For the woman, the soprano, mezzo-soprano, or contralto, and the for men, we classify it to the tenor, baritone, or bass. The soprano, it is the highest human voice, whose normal extension in 2 octaves. Now I want to just show some examples for the sopranos, the famous sopranos. One of the most exciting singers on the opera stage in the final 4 decades of the 20th century is the Montserrat Caballé. Ariana Grande is known for her 4 octave soprano vocal range. She's just a so popular singer, but she's also the soprano. The mezzo-soprano is the middle female voice and the most common of the female singing voices, which tends to dominate in non-classical music, with vocal range that typically lies between the A below the middle C to the A2 octaves above here. For example, just Madonna, Rihanna, Whitney Houston, and Adele, they are examples for the mezzo-sopranos. The famous contraltos, one of them, she's the Marian Anderson. Her voice was a rich, vibrant contralto of interesting beauty. It is the black population American, and she was the popular under so restricted periods of United States. The Kathleen Mary Ferrier was an English contralto singer also, and one of the popular contralto, one of them, she's the Toni Braxton. Her vocal range in 3 octaves. The 3 tenors, now about the tenors. The 3 tenors from left, Placido Domingo, José Carreras, and Luciano Pavarotti, and Andrea Bocelli. I want to just count of them, just which the popular tenors. Now, let's just remember just a normal laryngeal view, because now we should discuss with you just the laryngeal disorders. Okay, during the laryngoscopy for the normal time, normal breathing time, we should see such of the view, and during the speaking, the normal the voicing, we should see just the touching of vocal cords to each others. The laryngeal disorders classified, it may classify as an inflammatory disease. For example, acute chronic laryngitis, croups, epiglottitis, ulcers include them. Just maybe as a tumor, trauma, congenital, and miscellaneous origins. The miscellaneous, the laryngealipi are, just the laryngopharyngeal reflux. Which one of them is so famous in our decade? It is the example of the miscellaneous laryngeal disease. Or let's just discuss just the laryngitis. The inflammatory disease of the larynx, we call this the laryngitis. There are so many classifications, but we can classify it just the infections laryngitis, systemic disease causing, and reactive laryngitis in adult. The infections, we mean just that it also may classify into the viral, bacterial, fungal, and protozoan. I want to just show this the fungal laryngitis, this view. The moniliasis, it is the meaning just the candida, just the fungal disorders of the larynx. It's the view of it's the example for the fungal laryngitis. Okay, these pictures of this laryngoscopic view just belong to vaginal granulomatosis. We see systemic disease causing laryngitis. One of them, the so popular ones, is a vaginal granulomatosis, the rheumatoid arthritis, amyloidosis, even the sarcoidosis. So popular. Another classifications is the about the reactive laryngitis in adult. It includes it maybe after the LPR, laryngopharyngeal reflux, for example, this endoscopic view include belong to laryngopharyngeal reflux, the smoking, voice abuse, inhaler steroids, just angioedema and allergical view. View also, it's the example of them. The what in that slides we can see just the voice abuses. After the voice abuse, we can see it's the vocal cord hemorrhage. It is the very rare occurrence that usually is caused by aggressive or improper use of the vocal folds. It's a result of rupture of the blood vessels on the true vocal cord, with bleeding into the tissues over the fold. Okay. And maybe it is the oldest, it is the just the reactive classifications, includes the reactive classification. Another one is the intubation granuloma. It's a complication typically associated with prolonged endotracheal intubation. Now about the about the acute laryngitis. The predisposition factors, we can count the sound load, viral and bacterial infection, contact with chemicals. All these can lead to the laryngitis. Acute inflammation of the laryngeal mucosa is usually extension of catarrhal inflammation of nasal and pharyngeal mucosa. The disease is characterized by the hoarse voice, tickling, and dryness in the throat. The body temperature is usually normal and less frequently it rises to subfebrile. The main characteristic of acute laryngitis, the symptoms, clinical manifestations, it is the cough, it's the hoarseness, foreign body sensations. During the laryngoscopy, we're gonna see the swelling, hyperemia, infiltration, and incomplete closure of vocal cords. The patients with laryngitis every time just may present with the 3D symptoms. What is the 3D symptoms? We mean just the dysphagia, dysphonia, and dyspnea. Dysphagia it's related to the inflammatory process. Sometimes it's exposing first floor, our vestibule. Vestibule it is just related with the food pipe. That's why during the first it's during the vestibular parts irritation, it leads to the dysphagia. Dysphonia, it means this symptom is related with the second floor, because in the second floor is located our ventricles, our vocal cords, and during the inflammatory process in our vocal cords, it leads to the dysphonia. And the third floor, if the process is exposed to the third floor, I mean, it is the infraglottic cavity. Infraglottic cavity is directly related with trachea. There is the windpipe. That's why it leads to just with dyspnea symptoms. And the cough and stridor also may happen. It is in children. It may be as a barking cough and hoarseness. But we should do these cases with the differential diagnosis should be with the foreign body in larynx, upper respiratory infection, laryngeal spasm, and laryngeal diphtheria. Our treatment should be treated as soon as possible. The sufficient antibiotic therapy and systemic steroid for severe cases is very important. Inhalations with steam, the management of the laryngeal obstructions, stridor cyanosis, and retraction of subclavicular and intercostal spaces are indications of immediate tracheostomy. The supporting therapy includes the sedation and to be sure, water electrolyte balance. Okay, now we should just the should discuss is just the subglottic laryngitis. The subglottic laryngitis, another name we call this the false croup. It's the variant of acute catarrhal laryngitis, which develops in the infraglottic space. It occurs in children aging from 2 to 5 and is associated with the anatomy of their larynx, narrow lumen and loose connective tissue in the infraglottic space, and it's related with the structural peculiarity of larynx. Also, the onset of the disease is then real connected with an acute inflammation of the mucosa of the nose or the pharynx. False croup occurs mostly in children who tend to develop laryngospasm and suffer from the diathesis. The onset of the disease is sudden. An attack of barking cough occurs during the night to the sleep time. The child wakes up and tosses in this bed. Breathing becomes very difficult and whistling. Respiratory dyspnea is pronounced. The nails and the visible mucosa become cyanotic. The child is frightened and this intensifies coughing. An inspection of the child reveals retraction of the soft tissues of the jugular fossa, super and subclavicular spaces and the epigastric region. This condition lasts from a few minutes to half an hour. The child then sweats excessively and his respiration becomes almost normal. The laryngoscopic picture in subglottic laryngitis is characterized by ridge-like swelling of hyperomic mucosa in the infraglottic compartment. The most common age subglottic laryngitis is 5-8 years. Now